Namaste Vidya, Hamisha Khush Raho Vidya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Nephritic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to continue from the previous lecture of glomerulonephritis. In the last lecture, we have discussed about the nephrotic syndrome. Today, we are going to continue from the last lecture and we are going to discuss about the nephritic syndrome. In the last lecture, we had discussed about different types of glomerulonephropathies and the range, the variations between the glomerulonephritis to the nephrotic syndrome to the nephritic syndrome in case of glomerulonephritis. So nephrotic syndrome we had discussed in the last lecture. Now today we are going to discuss about the nephritic syndrome. So let's start with nephritic syndrome now. Nephritic syndrome, it is also known as acute glomerulonephritis. Now in the nephrotic syndrome, we have studied three things. We have studied about proteinuria, hyperproteinemia, and edema. Now what happens in nephritic syndrome? Nephritic syndrome is characterized by azotemia. Azotemia is basically high levels of nitrogen containing compounds, that is urea and creatinine. So in the nephritic syndrome is also known as acute glomerulonephritis, and it is characterized by azotemia. Azotemia is the high levels of nitrogen containing compounds that contains urea and creatinine, hypertension, edema, hematuria, proteinuria, and sometimes oliguria. So nephritic syndrome, it is also known as acute glomerulonephritis, and it is characterized by azotemia. Azotemia is the abnormally high levels of nitrogen containing compounds, that is urea and creatinine. There is also hypertension, edema, hematuria, proteinuria, and sometimes oliguria. So azotemia, hypertension, that is increased blood pressure, edema, hematuria, proteinuria, and sometimes oliguria. There is salt and water retention, and that is due to reduced glomerular filtration rate. So because of the reduced GFR, there is salt and water retention, and it is resulting into circulatory congestion. So nephritic syndrome, also known as acute glomerulonephritis, it is characterized by azotemia, that is increased nitrogen containing compounds, that is urea and creatinine, hypertension, edema, hematuria, proteinuria, and sometimes oliguria. There is salt and water retention. Salt and water retention are due to reduced GFR, and there is RBCs cast on the urine analysis that confirms the diagnosis. So presence of the RBCs and cast cells confirm the diagnosis of nephritic syndrome. So in the nephritic syndrome, we have azotemia, that is urea creatinine level increased, hypertension, edema, hematuria, proteinuria, and sometimes oliguria, and there is salt and water retention. So hematuria is prominent in case of nephritic syndrome, whereas proteinuria is prominent in nephrotic syndrome. So the red blood cells cast on urine analysis confirm the diagnosis. The clinical course of the nephritic syndrome, it depends on the underlying lesion. So whatever the underlying lesion may be, it is responsible for the management of nephritic syndrome. We have acute post-streptococcal glomerulonephritis. So in this, we have acute post-streptococcal glomerulonephritis. There is post-infectious glomerulonephritis. We also have rapidly progressive glomerulonephritis. And there is classification of the glomerulonephritis that are largely histopathological. A renal biopsy is required to make the diagnosis and determine the therapy in nephrotic syndrome. So we have clinical course of the nephritic syndrome. It depends upon the underlying lesion. Number 1, acute post-streptococcal glomerulonephritis. Number 2, post-infectious glomerulonephritis. Number 3, rapidly progressive glomerulonephritis. Number 4, classification of the glomerulonephritis. It is largely histopathological. A renal biopsy is required to make the diagnosis and determine the therapy of nephritic syndrome. Now, what is glomerular nephritis? Glomerular nephritis is basically nephrotic syndrome plus the nephritic syndrome. In glomerular nephritis, there will be minimal change nephropathy, primary focal segmental glomerulosclerosis. There will also be membranous nephropathy, IgA nephropathy, and the henoch purpura. Glomerulonephritis that is associated with infection, and acute post-infectious glomerulonephritis, and also rapidly progressive glomerulonephritis. So glomerulonephritis, it is basically nephrotic plus nephritic syndrome. There is minimal change nephropathy, primary focal segmental glomerulosclerosis, membranous nephropathy. We have IgA nephropathy and henoch purpura. There is also glomerulonephritis that is associated with infection. We also have acute post-infectious glomerulonephritis and rapidly progressive glomerulonephritis. Now, what is the minimal change nephropathy? We are going to discuss them one by one. So, first of all, let's discuss minimal change nephropathy. As the name suggests, there is minimal changes in the kidneys. The cause of minimal change nephropathy is basically idiopathic in 10 to 15% of the cases, and it occurs at all the ages, but 70 to 90% of the nephritic syndrome in children. So 10 to 15% idiopathic cause are there, and it occurs in all the ages, but 70 to 90% of the nephritic syndrome occurs in children. There is electron microscopy that shows fusion of the podocyte foot processes. The blood pressure is normal and the GFR is normal. So there is normal blood pressure, there is normal GFR, that is glomerular filtration rate, or slightly reduced. The urinary sediment is benign and may show few RBCs. So the blood pressure is normal, the GFR is normal, and there it is slightly reduced with urinary sediments that is benign, or it show few RBCs. There is proteinuria that usually remits on the high dose of corticosteroid therapy. So there is proteinuria and it remits on the high dose of corticosteroid therapy. The relapse case frequently need maintenance of corticosteroids. So if there is any sort of relapse, then high dose of maintenance dose of corticosteroid therapy is required. And this minimal change nephropathy, because there are minimal changes, so it does not proceed to the chronic kidney disease. So what is happening in minimal change nephropathy? The blood pressure is normal, the GFR is normal, or it is slightly reduced, and the urinary sediments is benign, and it may show few of the RBCs. So few RBCs are present in it, and high dose corticosteroid therapy is required. Second variety is the primary focal segmental glomerulosclerosis. Primary focal segmental, that is localized and it is related to a particular segment, glomerulosclerosis. The glomerulosclerosis refers to the scarring or the hardening of the glomeruli. So there is hardening and scarring of the glomeruli, and it can be primary or secondary. The primary Fsgs are the group present with idiopathic nephrotic syndrome. So there is idiopathic nephrotic syndrome, and no other renal cause of the disease are known. It recurs after renal transplantation. So after the renal transplantation, this is occurring, and some proteinuria recurs almost immediately and may lead to loss of allograft. So glomerulosclerosis, that refers to the scarring and hardening of the glomeruli. It can be primary or secondary. The primary FSGS group presents with idiopathic nephrotic syndrome and no other cause of the renal disease. It recurs after the renal transplantation, and sometimes proteinuria recurs almost immediately and may lead to the loss of allograft. The treatment of the primary FSGS typically begins with extended course of steroids. So due to the long course of steroids, this is happening, and it shows a little response to the corticosteroid therapy and often progresses to the renal failure. So primary focal segmental glomerulosclerosis often progress to the renal failure. The secondary FSGS occurs in the late stage of any form of the kidney disease. So it is occurring in the late stages of any form of kidney disease, and it is associated with the nephron loss. It presents with variable proteinuria and outcome. So there are variable outcome and variable proteinuria that is seen, and there is no benefit. In this case, there is no benefit of the glucocorticoid or immunosuppressive agent in the secondary FSGS. The clinical history and kidney size biopsy finding are associated condition that helps in differentiation of primary from the secondary causes. So if we want to differentiate between the primary causes and the secondary causes, then we have to go or look for the history, the clinical history, the kidney size, the biopsy findings, and also associated conditions that help in differentiation of the primary to the secondary causes. So clinical history, kidney size, biopsies, and associated conditions help in differentiation of the primary from the secondary causes. The histological appearance of the FSGS, but lesser proteinuria, focal scarring reflects healing of the previous focal glomerular injury. So the histological appearance with lesser proteinuria and focal scarring reflects the healing of the previous focal glomerular injury. And there is no specific treatment for this particular condition. The third variety that we are going to discuss today is the membranous nephropathy. What happens in membranous nephropathy? It is the most common cause of nephrotic syndrome in the adults. So membranous nephropathy is most common cause of nephrotic syndrome that is occurring in the adults, and it is characterized by subepithelial IgG deposits. The patient are present with edema and nephrotic proteinuria. So it is most common cause of nephrotic syndrome in the adults, and it is characterized by subepithelial IgG deposits. Patient presents with edema and nephrotic proteinuria. The blood pressure, GFR, and the urine sediments are usually normal at the initial presentation. So the patient here usually presents with the edema. In the membranous nephropathy, it is the most common type of nephrotic syndrome in the adults, and it is characterized by subepithelial IgG deposits. The patient is present with edema and nephrotic proteinuria, and the blood pressure, the GFR, and the urine sediments are usually normal at the initial presentation. There is hypertension, mild renal insufficiency, and abnormal urine sediments that develops later. 1/3 of the cases with membranous nephropathy remit spontaneously, and 1/3 remain in the nephrotic state, and 1/3 show the progressive loss of renal function. So the blood pressure, the GFR, and the urine sediments are usually normal at the initial presentation. The hypertension with mild renal insufficiency and abnormal urine sediments develop later. 1/3 of the cases remit spontaneously, and 1/3 remain in the nephrotic stage, and 1/3 show progressive loss of renal function. The treatment with high doses of corticosteroid and alkylating agents improve both nephrotic syndrome and the long-term prognosis. So there is blood pressure, GFR, and urine sediments that are normal at the initial presentation. Hypertension, mild renal insufficiency, and abnormal urine sediments develop later. 1/3 of the cases remit spontaneously, and 1/3 remain at the nephrotic stage, and 1/3 shows progressive loss of renal function. The treatment of this membranous nephropathy is with high dose of corticosteroids and alkylating agent that improve both the nephrotic syndrome in the long-term process. So this was all about today's lecture. We are going to continue with this glomerulonephritis, the other type of glomerulonephritis, in the next lecture. So I believe you have understood this session properly. And now it's your homework to go through the book, and you have to check for all these things that I have told you. You have to prepare your own notes related to this glomerulonephritis. Glomerulonephritis is not a simple topic, and you have to go through the book and prepare the notes by yourself. So this session is powered by digital version 2.0 JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve that. So this was all for today. Thank you very much. Have a good day.